We know that RBD appears when some circuits are dysfunctional, not functioning as they should. We know that RBD represents actually, among several dysfunctions, essentially a dysfunction of the system that keeps us paralyzed during rapid eye movement. So when we dream, when we have these vivid dreams, we are physiologically atonic, that means paralyzed, and this is actually protection from acting out our dreams. So the essence of RBD, and not the entire phenomenon, relates to this loss of muscle atonia, and this is a brainstem function. Now, we have learned over the last 20 years that different Parkinson patients may have different trajectories and different patterns of neurodegeneration. And in some cases, this pattern includes early on dysfunction of the system that keeps us paralyzed. This is a descending pathway coming from the pontine structure to the medulla and then to the spinal cord that keeps us paralyzed. If this comes along early, then RBD will be, among the first manifestation. If, and this is known to happen, in the process of neurodegeneration, this system is not early on dysfunction, then RBD may follow later on. I would like to insist on another element of the of the current knowledge, and that is that not only the brainstem is involved in the appearance of RBD. This is the I would say historical interpretation based also on animal studies showing that you can induce RBD like syndrome in the cat, Jouvet's experiment of the 1960s. But we have learned over the years from animal, but also from human studies, that the appearance of RBD depends on a dysfunction of this atonia system, but also on the activation of limbic, cortical, subcortical circuits, which again may differ from one patient to the other depending on where the neurodegeneration takes place.